Alors, bonsoir tout le monde.
Good evening, everyone.
Rochelle m'avait dit que je pouvais préparer des
Rashane told
slides
me
pour ma
that I could prepare
présentation,
some PowerPoints for
mais
my
en fait,
presentation,
je n'ai pas ressenti le besoin
but actually I did
parce
not
que la
feel
maladie
the
de Crohn, c'est
need
quelque
to
chose
do
que
so
je connais
because
bien. Donc, c'est pas
Crohn,
quelque chose que j'ai
Crohn's
besoin
disease is
de
something that I
préparer
know
pour
very well,
expliquer de
and I
façon.
don't feel that I need to prepare
Ensuite, de ne pas
anything
avoir de
to
PowerPoint
be
vous
able to
permet
discuss this
d'écouter le match de
issue
hockey,
with you.
de
So
regarder le match de hockey pendant que vous m'écoutez
also, if you don't have a
dans ma
PowerPoint, you
présentation ce
can
soir.
see the
Donc, un petit peu
Canadian
mon
games tonight
parcours
at the
et
same time.
notamment
So, to explain a
l'importance
bit
de
about
votre
my history, and I think
présentation,
it's important for tonight's
j'ai mon
presentation,
diagnostic,
I
j'avais
was
alors 11
diagnosed
ans
at
dans
the
une
age of
région
11
rurale au
in a
Nouveau-Brunswick.
rural region of New Brunswick.
Donc, mon parcours avec la maladie de Crohn
So, my
passe de
journey with
l'enfance à
Crohn's
l'adolescence
disease was
à la vie de
from
jeune adulte
childhood to
jusqu'à
adolescence to early
mon quarantaine
adulthood and now
aujourd'hui.
to today. I'm
Ce que
44 years old
ça
today.
le vécu pendant mon enfance,
So, what I
peut-être
experienced when I was a
c'est aussi
child,
bien ou peut-être moins bien que
well,
les symptômes
you
de la
probably
maladie de Crohn. Ça
know
a un impact
the Crohn's
important
disease
sur la qualité de vie
symptoms,
des
but it has an
personnes. Et
important
pour
impact on
un
people's
enfant,
quality of
ça a
life.
été
And
extrêmement
especially for a
difficile.
child, it was extremely
Au
difficult.
niveau de l'enfance, c'est les parents
When I
qui
was a
prennent
child,
les
the
décisions pour
parents
les
are the
enfants.
ones
Donc, tout
making
ce qui est
decisions for you.
examens médicaux,
So
les
everything that had to
anticonceptifs,
do with medical exams,
la médication,
diet,
ils ont moins
medications
de, disons, choix à faire,
were
tandis que les
not my
parents
choices. Your
s'en occupent.
parents take care
À
of
ce
that.
moment-là, bien sûr, manquer beaucoup
At that
d'école
time, of
quand
course,
on
I
ne se sent
missed a
pas
lot of
bien.
school when you don't
Donc, ça a
feel
été
good.
difficile pour le parcours scolaire.
So it was difficult for my
Ce que
school
je trouve
journey.
important aussi, quand j'ai reçu mon
So
diagnostic, j'étais l'une
what
des
I thought
plus
was
jeunes
important as well is
personnes
when I got my
avec
diagnosis, I
un
was one of the
diagnostic de maladie de
youngest
Crohn dans cette
with a
région-là
Crohn's
du
disease
Nouveau-Brunswick.
diagnosis in that
C'était
region
vraiment
of New
la
Brunswick.
majorité des personnes,
The
c'était des personnes
majority of
âgées.
people were
Donc,
elderly
en termes, je me
people.
souviens d'être allée à des meetings
So I remember going to meetings
pour les personnes souffrant de la
for
maladie,
people
mais ça
suffering
ne me
with
représentait pas du
Crohn's
tout parce
disease,
que
and
j'étais
it
assise
didn't
dans une
represent
salle
me
avec
at
des
all
gens
because I
dans
was
la
sitting in a room
soixantaine,
with people in their 60s.
Au niveau de l'adolescence, c'est là que ça a été
So
plus
during
difficile, je dirais, pour
adolescence, it was
moi,
harder, I would
parce
say, for me.
qu'avec un diagnostic à l'âge de 11 ans,
With a diagnosis at
avec
the age of
une dose
11
de corticostéroïdes
and
importante,
intaking a
il y a un
very
effet
good
sur
amount
la
of
puberté.
corticosteroids, I had effects
C'est
on my
beaucoup plus
puberty.
important pendant
Symptoms
l'adolescence.
were more
L'adolescence, ça peut
intense
être
during
déjà une
adolescent years.
période assez difficile
So
pour
teenage years are
toute
already a
personne
difficult
qui n'a
period
pas
for
de
anybody.
maladie. Donc, imaginez quand on
So can you
souffre
imagine when you
d'une
are
maladie
suffering
chronique
from a chronic
avec des
disease
douleurs importantes,
with
euh,
important pain
le besoin d'aller à la salle de
and the
bain
need
constamment
to
avec
use the
diète
washroom frequently
et
and to have
les
a
premiers
special
parties,
diet?
l'alcool,
So
même
think
si on n'avait
about
pas
first
l'âge.
parties, alcohol, even
Tout
when
ça
we're
a
not
été
of age.
vraiment
All of that
bouleversé dans mon
was
cas. Ça n'a pas
very
été une
much
adolescence, comme on
difficult in
dit,
my
disons,
case. I didn't have the
normale.
a
C'est vrai que
regular
ça a été difficile
teenage
quand les
year
gens, par exemple,
or teenage experience.
avaient leur premier
So when
party
my
ou
friends had
sortaient
their
avec
first
des gars
party
ou
or
n'importe
went out with
quoi. Ben, moi,
boys for the
j'étais
first time,
hospitalisée, par
well, I
exemple,
was in the hospital.
quand les gens allaient dans des
Or
restos,
when
d'aller voir
people
des
would go to the
cinémas.
restaurants or go to
Moi,
movies,
je me sentais pas bien, je restais à la
I
maison.
didn't feel good. I had to
Tout ce
stay
qui était
home.
diète aussi était
And
difficile parce que
everything
dans
that
un
had to do
contexte
with diet as
social,
well was difficult
tu
because
veux
in a
manger du
social
popcorn quand tu vas au
environment,
cinéma,
you
tu veux
want to have
manger
popcorn when you're going to
certains
see a
aliments avec tes
movie.
amis,
You want
à
to
ce
eat
moment, la
certain
diète ne
foods
te
with your
permet
friends,
pas.
but the
Et
diet
à cette
does not
étape-là
let
aussi,
you.
l'enfance, les parents
And
prenaient
at
des décisions,
this
la
time
maladie
of my
est
life as a young
présente.
adult,
Mais là, il y a le
once
parcours
again,
aussi de
oh, but there's also
l'extra-entérologie
the
avec
gastroenterologist, the
l'ophtalmologie
pediatric
pédiatrique à
gastroenterologist.
gastro-entérologue pour adultes. Donc, tu prends tes responsabilités. Là, tu deviens
So a
responsable
young
de tes
adult
rendez-vous.
must become
Tu
responsible
peux aller
for
chercher
their
tes médicaments à la
meetings,
pharmacie,
to go
de
and
suivre ta
retrieve their
diète
medication at the
du mieux que
pharmacy.
tu
You need
peux.
to follow your diet as best as you
Je m'amène
can.
maintenant à la vie adulte,
So which brings me to the adult life
ben, écoutez,
today.
c'est vraiment possible avec
Well,
les nouveaux
listen, it's
médicaments, comme je
really
disais.
possible with the
Moi, en
new
particulier, c'est
medications or the
l'infliximab,
new
les Remicade, que j'ai
prescriptions like
commencé en
Remicade
2017.
that I started in
Ça a eu un
2007.
effet immédiat,
I
vraiment
had an immediate
immédiat,
effect with
sinon
that.
miraculeux, sur mes symptômes.
I could even say that it was
Donc, ça m'a
miraculous.
permis de terminer mon baccalauréat en droit
So I was able to finish
Ça m'a
my
permis
bachelor's
de
degree
trouver un
in law.
travail à temps plein
I was able to find a
qui m'amène
full-time
un
job.
garçon de 10 ans.
I am the mother
Et ça,
of a
c'est quelque chose que j'avais
10-year-old
discuté
boy.
avec mon gastroentérologue
That
quand
is
j'ai
something
voulu
I
tomber
discussed
enceinte.
with my
Premièrement, je ne savais
gastroenterologist
pas
when
si
I
j'allais pouvoir
became pregnant.
avoir un enfant à
Pregnant.
cause du
First of
délai
all, we
immédiat
weren't
pour
sure
avoir
if
un
I was
enfant.
able to get it, to have a
Finalement, ça
child,
s'est bien passé.
but in the
La
end,
discussion
things
de la
went well.
médication pendant la
We
grossesse, est-ce que
adjusted the
c'est OK? Est-ce
medication
que c'est pas OK? Et je suis aussi
during my
une
maternity,
épouse. Je suis
and
capable
I'm also a
de faire
wife.
des voyages.
I'm
Donc, c'est
also
sûr que
able to
la maladie a
travel.
toujours un impact dans la vie,
But
mais il
of
faut que
course, the
tu
Crohn's disease has
en
always has
engages
an impact on
parce
your
que
life. In English, we would
honnêtement,
say
même
we always have to
si
make the most of it.
profite de la vie,
You really need
mais la réalité, c'est que ta vie est un peu différente.
to have fun in life.
Puis,
But the reality
salle de
is,
bain,
your life is a little bit
c'est
different. So the
nécessairement
bathroom
bien
needs to be
contrôlé.
close by, even if
Il y a
your disease is
toujours,
well
il y a peut-être
controlled
une
or is under
coiffeuse à côté.
control. It would be the
Donc, vraiment, pas besoin
irritable bowel
d'aller salle de bain.
syndrome. So
Médicaments,
needing to go to the
il y
bathroom
a toujours des
frequently.
médicaments que je dois prendre.
There
Je
are
suis
medications that I
sensible
always have to
des
take.
genres de
I
virus,
am
des
more
vitamines B,
sensitive
donc
in terms
gastro,
of bugs
ça me
and
dérange
viruses
beaucoup.
or
La COVID, ça a
different
troublé tout ça.
gastro
Je
bugs.
suis
And COVID
immunosupprimée
was
aussi avec la
really
crise
scary for me
de
because
Remicade.
I am
Donc, ce n'est pas
immunodeficient
terminé,
because of Remicade
mais
intake.
on est capable d'avoir
So it
une
is
vie
not
pleine et
over
entière,
when
même si
you
on souffre de la
become an
Crohn.
adult, but you are able
Et
to have a
depuis
fulfilling
mon
life
diagnostic
with Crohn's
jusqu'à
disease.
aujourd'hui,
And I realized
les
that
traitements
since my
médicaux
diagnosis
se sont
up until today, I've noticed that the
améliorent
medications and
au cours de
treatments
temps.
have greatly
Puis, il y a des
improved,
personnes qui souffrent
and
de
they
Crohn
improve the quality of life of
depuis ça.
people suffering with this disease.
Alors, je pense que ça... I could speak a bit in English if you want, or...
Sure.
Okay.
You want
So
to-
just briefly in English, I explained the different phases of life for me being diagnosed as a child. So I went through adolescence, then a young adult, and today an adult. I'm now 44 years old. When you're a child diagnosed with Crohn's disease, you don't really understand what's going on. You feel the pain, that's for sure, and you have to go to the bathroom, but really the responsibility kind of falls on your parents to make the best decisions for you, and on your parents to make sure that you go, make doctor's appointments, go to them, take your medication, get the medication in the pharmacy, go to medical exams. But that changes during adolescence, where there's more responsibility on you to take your medication, to follow your diet, which is not always easy when faced with social situations. Adolescence is tends to be kind of a hard part for everyone. So it is especially for someone who suffers from this type of disease, which brings us to young adulthood. And then you switch from a pediatric gastroenterologist. And, managing your disease really becomes your responsibility, where you need to advocate for your care. You need to take care of appointments, medication, and your life will be different. That's for sure. But there's still hope, and with new medication, since my diagnosis, I think that's something that's really, really made progress with the medication, because it's changed my life completely. I've been able to finish law school, to work full time. I got married, and I have a 10-year-old son. So my life is not, it's not perfect. Crohn's is in remission, but there's still a lot of a lot of issues such as using the bathroom quite frequently. I'm more susceptible to viruses or stomach bugs, tiredness. I think, the different stages of life, I'm happy to be where I'm at. And I think it is important to enjoy life to the fullest, even though you suffer from one of these diseases.
Thank you so much, Jessica.
Thank you.
I know we had spoken previously, so I had heard your experience then, and I knew you would be extremely impactful for today's talk. So thank you again for sharing your experience, and I'm sure it resonated with a lot of individuals here. Now we will move on to understanding IBD through the different stages from a clinical perspective with Dr. Jantchou. The thank you slide. So Dr. Jantchou is a pediatric gastroenterologist and researcher at St. Justine Hospital. He's also an associate professor at the University of Montreal. He obtained his medical degree in pediatric gastroenterology in France before pursuing a PhD focusing on the risk factors for IBD. His academic and clinical work combines research, patient care, and teaching with the goal of improving IBD care for children with chronic gastrointestinal diseases. Dr. Jantchou is also a remarkable medical communicator and has over 500,000 followers on social media, where he uses innovative digital formats to make complex medical topics accessible to everyone and raises awareness about health and prevention. So again, thank you, Dr. Jantchou, for being with us today. I'm very excited for you to share your expertise with us. So please take it away. I'll also stop sharing my slides. Oh, perfect. And also for the interpreters, Dr. Jantchou will be talking in French, so please switch to English. Thank you.
Thank you so much for the warm introduction. I would like tout le monde. Je suis très flatté d'être aujourd'hui.
Hi, hello everyone. I'm really excited to be with you today. I would like to first thank Jessica for her story. She talked about pediatrics and her journey, and it's always fun to see where the patients go after we followed them for many years. So today I'm going to talk about the intestinal inflammation disease. So there might be questions at the end, but it's always good to go over the basics to make sure we're all on the same page. In the room, some people might be touched by the disease, or some may be some family members or caregivers. So I think we need to understand the inflammatory bowel disease. We need to distinguish it from the irritable bowels. So these are frequent diseases across Canada. We have many patients suffering from these diseases, and we estimate that in 2035, 470,000 Canadians will suffer from one of these diseases. At the scale of the nation, so 11,000 people diagnosed in 2023, so that is one person every 40 minutes, and in 2025, it'll be one person every 20 minutes. So all of these issues are important because these are chronic diseases that evolved with different phases and with remission phases as well. So the goal of medical care is to bring patients to a comfortable life through the different pathways that we will cover today. So we often say, how do we look at life? You can look at it from the end, sometimes from the beginning, but I thought I would position myself in the middle today. I'll position myself at the point where the young pregnant woman wants children and suffers from inflammatory diseases, and will go back to childhood and once again, back to the adulthood and to elderly ages. So this is a journey that we will embark on together. So for example, with maternity and labor, we need to keep in mind how to go through this maternity that I'll show you later. We'll also talk about medication. So we do not want to hinder the fetus. So one thing that research helped us understand is the mechanisms of fetal toxicology. We'll talk about issues with the spouse and also issues during labor. So one thing that is well established is that women affected by Crohn's disease have a fertility level that is comparable to other women. It really does not affect fertility. Of course, the active disease can bring about inflammation and have impacts on the momentarily decrease the fertility levels, mainly with men, and everything that has to do with the anatomy in the pelvic area can have an impact on the fertility levels. For example, we need to plan to control maternity. So with the recent research, we noticed that the majority of current medications are compatible in someone's life. So the first semester, for example, we will be assessing the disease. We need to supplement the women as if with other women with folic acid and vitamin supplementation. So for the second trimester, we have closer monitoring with monthly consultations and monitoring of nutritional status and adjustments of preparation for delivery, discussion of the mode of delivery based on the disease status. So most women with an inflammatory disease can give birth with natural ways, but certain issues will bring them to make a choice, for example, go into cesarean. So when we speak of all of these phases, we speak of controlling and managing the disease. We don't stop the treatments during pregnancy because we want to remain in remission. Because an active disease, the proper medication, most medications that exist are pretty secure, pretty safe. So the medications that are used are aminosalicylates, 5-ASAs, and they are efficient for this disease. Not as much for Crohn's disease, but they seem to be safe during pregnancy. Corticosteroids, these are used to treat symptoms, and we're trying to avoid those medications. It's just in case of symptoms. Those are not the fundamental treatments. But when the disease is active, it is possible to treat it with corticosteroids, but we generally try to avoid those during pregnancy. Then we have immunosuppressants that are used for the Crohn's disease. We have the azathioprine, the 6-mercaptopurine, and the methotrexate. They can all be used, but methotrexate must be avoided at all costs because it could cause malformations of the baby. So another family of medications, we have the anti-TNFs. We have 20 years of studies on these medications. They come from under different names. There are biosimilar medications. They could be done per us or with subcutaneous injections. So we can use those on the first trimester. It's good. But for the third semester, there is a possibility that the medication infuses through the placenta. So we use precaution in this period. So later, I will show you one thing that was published recently concerning the possibility for a baby to have a normal immunization, a baby born under a mother that was using anti-TNFs. So the adalimumab and Remicade are very efficient in the disease. So we have new therapies that came out in the last years. We have the ustekinumab and the vedolizumab. So the ustekinumab and the vedolizumab are pretty safe during pregnancy, and there are more and more used. But the small molecules that are even more recent, the one that finished with the word IB, so if you see a medication with NIB, these are the Janus kinase inhibitors, and they are medications that we take by mouth, and they are mediators, and they are efficient to treat Crohn's disease and irritable bowel syndrome, but there is not enough data on their use. So for the inactive disease, we will use it with someone that did not have any success with other medications. So it's important to have this discussion with the gynecologist and the gastroenterologist at the moment of pregnancy. So another point that is important when we talk about pregnancies is breastfeeding. So most medications that are safe during pregnancy are also safe during breastfeeding. So it's important to keep that in mind. So we have biotherapy like infliximab and lamutimab are considered safe, and corticosteroids and aminosalicylic can be used if needed only. So we do encourage the mothers to breastfeed because breastfeeding brings a lot of advantages for the child, and it is not an act that will influence the aggravation of the disease. So another question that was asked is the fact that we give medications to a pregnant woman, can that affect the baby's growth? Because we know that those medications can decrease the immune system. So the question was, can this influence the baby? So a mother that has an inflammatory disease has greater risks of having a baby that develops an inflammatory disease, and the difference is between 15 to 20% more than a regular child. And this goes through the diet, through breastfeeding, but it is a beneficial microbiome. So some medications go through the placenta. So we do not favor these medications up until 6 months for the children to avoid there is a transmission. So some vaccines are good. We have the rotavirus vaccine protecting newborns and the gastroenterite viral virus.
And there was a study was done in 2023 to find out the authors that were looking at for babies that were born from mothers under treatment, biologics, and receiving infliximab, adalimumab, nivolumab, estimumab, and those children were exposed during the growth, and the authors have noticed that the immunological statute and administrating the vaccines for every child. And the good news is that it was very secure. No secondary effects at 7 days or a month or 9 months after vaccination. So those are data that are pretty encouraging to say that even if the creatine or even if there were impacts on the development, immunitary development, we have signals that are good, and we can protect the baby like any other. And so I was talking before about the risk of developing inflammatory disease. If there's a mother or father that has it, the risk is higher. And if both parents have it, the risk is even higher. And so these are the data that are very established right now. But the genetics by itself does not explain why children develop inflammation. And that will be the transition with the second part of this presentation, that is the inflammatory disease for children, inflammation disease. So we need the genetics does not explain everything. There are other factors, the environment, the factors around food, and we've done a conference on this subject. Possibly you will see in the chat on the factors and risk of the environment that we're always with Crohn and Colitis Canada. And on that conference, you can find a bit more what we've discussed, and we'll able to publish an element that was very important with it, is that smoking, passive smoke, which also explains why certain children develop inflammation, and in part by smoking, active smoking, when the child becomes an adult. But there are other elements in place, like the exposition to antibiotics, food, nourishment in the first years of life, that will modify the microbiome of the intestine. And as a doctor taking care of patients with Crohn, inflammation, ulcerative colitis, and also at the St. Justin where I work, it's 150 to 160 cases every year of inflammatory sickness, or IBD, and most of the times it's Crohn more than ulcerative colitis. And there are issues around this sickness for children, especially the question of genetics, the lack of development, and the symptoms are also present, and other issues for the impacts, psychological impacts, and where Jessica spoke about it, about everything that's self-image, social life, and with other teenagers of the same age. And those are issues that we will talk about a bit later. So what happens for children? The children with chronic inflammation can manifest development in problems in their weight, in their height, pain in the stomach, diarrhea, blood in... we see a slowing down of the growth. So why are there a problem with the growth? And it's linked with inflammation. Inflammation produces chronic phenomenon. And C, that gives to the body the work of using the nutriments against inflammation. So certain inflammation, chronic inflammation, and malnutrition sometimes happens, will affect the development for the size and the height. And so it is a tool that we use in pediatrics, the growth curve, to see how children will grow in time. The question of health, bone health, children with IBD are increased risk of osteopenia and osteoporosis, weak bones, a risk of fracture that's important, and questions also on minimizing the exposition to medication that will make that case even worse, osteopenia, cortisones especially, and corticolis. And so what are we doing in pediatrics right now for these inflammation disease? The clinical data that we use, the exams, and one thing that's important is also to be able to help people to communicate on their symptoms. We've had at many different times youth that had blood in their stools, but weren't looking at their stools, and that lasted for many weeks. And it's only afterwards that fatigue is installed and sets in, anemia sets in, and we realized that there was a sickness that could have been diagnosed 6 months or to a year before. And the same thing for perennial problems, fear, and prevents these children and teenagers from saying that they have pain. Or that they have discomforts. So those are one of the issues of pediatrics, also to be able to give the children the possibility expressing their symptoms, and especially that they feel comfortable to do so. Afterwards, the tests that exist will help to orient us in the diagnostics and eliminate the diagnostics that are differential. We look at the blood test, inflammatory markers, and there are markers that are very interesting in endoscopy that will confirm the diagnosis, and an element that we could also use to do the follow-up. But the markers that are non-invasive are often interesting as well. And so the issue there is certain young people do not want to do these tests because they're a bit shy of using and manipulating their stools. In pediatrics, we're trying to get away from evasive things such as having the echography and a scan, MRIs, and radiations for the body. And so those are the issues for the diagnosis, for that level, and the issues for the treatment now. And once again, the privilege of certain treatments will let the children have a good growth and to catch up in their growth and to avoid complications. So we prefer eternal nutrition over corticosteroids. And it's not easy in certain treatments to drink only certain drinks for a specific time for 2 months, and sometimes some people do not get to the end of it. Like immunomodulators and biologicals also have a place that more and more marked, because before we had an approach that was an approach we're starting with nutrition. We increase with the immunomodulators. We increase with the biologicals. But right now, we're with the approach where the severity of the sickness will guide the aggressiveness of the treatment. So we'll have patients that will start with the biologics, and in our cohort in Saint Justin, for example, in the last years, we're at the 70% or 70% that are exposed to a biological in the 3 months after the diagnosis. So those are treatments that will win in comfort and quality of life, and to avoid different issues. When we're 16 years old, we don't have much time to catch up, so we have to go pretty quick. And so those are medications that are very effective. And so the impact, social impact for children is manifest. And so the question of social isolation and symptoms, it can be unpredictable symptoms, frequent hospitalization. The effects of visible treatments can lead to a feeling of isolation. Kids that have issues every month, it is half a day, lack of school. And if besides that, they're considered the hospitalization, it is also problems around being absent and isolated. So anxiety and stress, the chronic and unpredictable nature of IBD can generate significant anxiety and constant free of flare-ups. About 30% have 30% chances of irritable issues. So they could also affect that will bring to certain patients difficulties in school. Question of chronic fatigue and pain will also affect concentration and academic performance. And so the importance of being able to listen to those young people, listen to the teenagers, accompany them with a follow-up and a medical follow-up that is important. Psychological follow, ideally, to be accessible to all. But there are issues around the access and a psychologist, and it's important to be able to use strategies and sometimes support groups and being part of organizations like Crohn Colitis Canada. When we do events, there's a lot of young people that come and could help them in school. But pediatrics is also, when we are in pediatrics, especially when the diagnostic is still young, and children that we have in our hospital, about 25% of them are less than 10 years old. So that's a great proportion of children for which the parents are the actors of their administer the treatments and verify the meetings and organize the blood tests and encourage the young people to do their own tests for their stools. And so parents will also have an important role on the nutritional, and even if certain regimes are good and exclusive to those who are on this sickness, especially those who are in biologicals, should have a nutrition that is good for them, and encourage the parents to be able to give those young ones good nutritional support. And so that is an issue that's important for the parents. And when the child grows and becomes a teenager and attaches himself little by little, and we have different other situations like corporal care and like corticotherapy, their medication that can bring physical changes to their bodies with weight, acne. It could be difficult to accept during the teenage life. There could be issues around marks, surgical marks on the body, even if we have a big incisions and the scars are huge, and so sometimes it's less important as a scar, but the presence of histamines that can affect the self-image. At an age where appearance is crucial and where children between themselves are not always kind. And so accompanying the teenager in the management of the corporal image is one of our objectives as well. Other challenges of a teenage life is adherence to therapies in a period where there's a questioning of authority and a desire for independence, which can result in fluctuating adherence to treatments. And that's at about more important for the treatments that we're asking the teenagers, how many times did you forget this month to take your treatment? It is something that is almost always there. Teenagers forget once or twice, but a certain group that forget a lot more, and certain even forget their biologicals. On himself to stop his treatment and presented himself in consultation almost a year afterwards because the symptoms had come back in a stronger way. And that is an issue that we are trying more and more to tell them on the diagnostic that they don't miss your treatments. But we have not have a date for the end. In pediatrics, we're never stopping until they get to 18. And the adults we'll see later, but certain tests that have been done to try to control and where people have fallen back. But in pediatrics, it's really treatment that we give during the whole period. Another issue and challenge, seeking to belong to a group and can lead to inappropriate behaviors such as alcohol or tobacco use, vaping and marijuana, cannabis, that are things that could be negative and harmful in the context of IBD. We know that smoking is a major aggravating factor in Crohn's disease, not only a factor that's risky, but is a factor that's an evolution. So we try to prepare the young people around that, and we encourage them. We help them to look at their. We could look at medication that works properly, but they should be administered. And to make it better, we're going to work with the education of the therapies and digital tools. We're going to help with the peer involvement and adapted communication. Direct exchange between doctors and the teenager, and for that reason, for example, that we're present on social media to them and to convince them of the necessity of taking their medication, that sometimes that can be a negative. And we have showed it as well that recently that by putting together an application, a digital application for the following of the sickness, when the sickness is controlled, that they don't feel like talking about it. They don't want to think about other things. And so it's really those moments where we have to insist because that the path of life will bring them at one point to getting away from the parental role and the transition towards adult life. And that transition, we prepare them very early, 14 to 16 years old, for the first phase, to be prepared. We evaluate the needs and the knowledge and the sickness, how it happened, what exams that we've done, and you will remember. And then next time you will talk to me about this. We'll ask them a bit to tell me about their disease and the exams and that phase. Remember, it's very important. So that transition, active transition around for 16 to 18, where we're starting to learn how the health system functions, and how we are going to be able to transfer where and with who, and finally the transfer that ends at 18. And that phase of the transfer is they're arriving in the medical office. And there are some cases where we don't get there at 18 on the nose. A transfer complete to the adults is very important, where autonomous is encouraged. Oftentimes the parents can accompany for the first visit, but we try as well to encourage that detachment, to let that young adult take care of their own health issues. There are tools that exist for this transition, and there are also medical passports that look at the history of the patient. There are questions of evaluation of the autonomy that will be able to identify the points to reinforce their joint consultations, facilitating the sharing of information between teams. In Quebec, for example, there were a few years ago the TRAC that were put together workshops to unite the young people and try to help them with and talk about their health and talk about this transition. And so there are different work underway to put other ways in Saint-Justine, notably to facilitate the transition. So it's really a path and not all years old. And so the consultations during the diagnostics or the family doctor will send us the patient, and after we will meet the patient, we will do the exams, announce a diagnosis, put a treatment in place, and do visits to follow up. And sometimes for certain patients, there are issues where there's a relapse, and the patient will come back with exams and endoscopies and adjustments and therapies. And so that is something that we are careful with, because we really want to control the disease as much as possible. And it was demonstrated, for example, in a study that we have done, that we have demonstrated that the patients after the diagnosis, a great proportion of them or it took up to 90 days to have remission completely. So that means that the sickness, even if it got better, the disease was better. There was a latency observed. And so the disease being under control is in remission, and there's still a certain proportion that is with a relapse. And that is an element for which we are trying to aim for strategies to improve the evolution of the disease and decrease the risk of relapse. And so when everything goes well, the youth, after a certain time and finding the right treatments, and that becomes a young adult that he is, that there are other issues, there are different issues that show up. And so we'll go in the part 3 where we'll talk about IBD in adults. So we'll talk about the issues around a professional life. We'll talk about issues around advanced treatments, new biotherapies, issues around the risk for intimate relationships, and the risk around a long course. And so already the first thing is that there's a tool that is fundamental, whether it be for the child or the adult, is nutrition. That is an important key for taking under control and the follow-up of the patients with the IBD. So there are certain foods that are important to avoid, but the patient must have good health food and not use transformed food, food that has emulsifiers, conservatives, preservatives. And when it's controlled, we can introduce fibers and identify those that are triggers of the disease. So there are different food that's been put in place. Some regimes are more effective than others, or some diets are more effective, and the most important is to identify for every patient certain triggers, and it's not always easy. And so in the strategies of treatment for the inflammation, the evaluation, as for the child, has the endoscopy. We do coloscopy, gastroscopy. It's an evaluation that will be able to determine the severity of the delay of extent of the disease. Another strategy that's important is to have objectives that are very clear. Remission, for example, the clinic is not enough. We try to bring remission, and so the goal of the treatment will go all the way up to the remission, as being associated less risk of relapse, where hence the closeness of these clinical verifications. So the approach that we call optimizing the target is really an approach that is fundamental. So patients with IBD will have this approach with the treatments of the first line treatments that can be used in like the 5 aminosalicylate corticoids. They're used to control inflammation in case of an event, modulators, and biologics and the small molecules that are treatments that we've seen beforehand that are more recent. And so beside of that, we still have to think about the lacks. Oftentimes during the diagnostics, there's a lack in iron. There could be a lack in vitamin D. So patients with IBD can necessitate a treatment. And that treatment of an operation, a surgery, and it is not always uniquely in case of a problem of other treatments, but it can be observed in certain forms. For example, there are some patients who have a very short, localized that warrant a small operation, and we remove the sick part. The other treatments are in case of a failure, when we have a colectomy that is so severe and does not respond to other treatment. So we could have stenosis with the part of the colon on the left or the right, pardon, and ileocecal, and a part of the right colon. We can have ileostomies that are put into place. And then there's the question of perennial fistulas that are procedures aimed at to drain infections and close to the fistula tracts. And there are improvements at 70% about of the people who had this issue, 7% of them have required surgery. Now we've reduced that percentage, and it's also the importance of starting early with a treatment that's more aimed. Those who have ostomy also have issues around different daily care. So living with ostomy care is gradual with the help of stomach nurses, techniques of the pouch change technique, products, modern products that are discreet, leak-proof, and minimize odors, allowing daily activities. Body image accepting the ostomy is a time-consuming process. Discussion groups and exchanges with other ostomy patients facilitate the adaptation. Clothing can be adaptable to conceal pockets, and intimate life is fulfilling sex life is still possible with ostomies. Accessories such as mini bags or stomas covers can be used in having access to specialized sexology consultants. So they have also in their life issues and manifestations that are extra intestinal manifestations of IBD, and that could be a high percentage. If we take, for example, the manifestations that they're articular, 15 to 20% of patients can have a peripheral arthritis affecting mainly large joints, knees, ankles, wrists, or the spine and joints and little articulations as well. Manifestations can also be on the skin or ocular manifestations. Episodes can occur independently or bowel activities, and skin manifestations, erythemas, nodulums, presented as painful red nodules on the legs or on the feet. Other manifestations that are also frequent are the manifestations that touch the fibrosis of the bile ducts, affecting 2 to 10% of the patients with ulcerative colitis, and that evolves into independently of the bowel activity of the disease. So this needs verifications by MRI and monitoring of lab tests, and fatty liver in IBD patients. We've had them regularly, certain cases of hepatitis linked to these. The regular biological monitoring is necessary to detect any abnormalities, and doses adjustments or change of treatment may be necessary in the event of significant elevation of liver enzymes. And then there's other risk, thrombotic complications, especially in a rising or flare-up of the disease, and when there's a prevention. And so if we ask it to give anticoagulants during a flare-up, it's not have these issues, avoid these issues, and to have different attacks that will be attacking different vessels and give different complications. And so the other thing in the adult life and the path with these patients is a prevention of complications of cancer. And the risk of cancer is a preoccupation for the enterologists, a risk of colorectal cancer. And so you have to watch for it in patients that have even this remission of IBD can have a coloscopy of at least years after the last one, if the disease is in remission, and a follow-up that can vary from 1 to up to 5 years according to the findings of the coloscopy of dépistage.
And there are stages of cancer. You can have polyps, as you can see on the image. Here, we're not at the cancerous stage, but cancer can show up with gradual progressions. So monitoring of cancer enables us to avoid these stages. And one thing that's coming up in the next years is to see if that we use the medications preliminarily, will it help us reduce the risk of cancer? That is something that we are studying more and more. But most patients living with an inflammatory disease are doing well. Even though I spoke of all of the risks, they do have a normal life. They have normal physical activities and a job that is appropriate for them or that is satisfying. But they do need medical consultations, imaging exams, monitoring of the biological blood samples, and treatments. So treating the patient globally is another of our concerns. In pediatrics, we do not only want to treat the organ, we want to treat the patient globally, holistically. We'll talk about physical activity, we'll talk about sleep, we'll talk about alcohol, tobacco, etc. Sleeping hygiene is important. Stress management is important. Stress does not cause inflammatory diseases, but it can exacerbate its symptoms, and it can also trigger flare-ups. So we need to look at the patient holistically. It is essential. And as for children, psychological support is fundamental. We know that there could be depression rates that are higher, almost twice as high as the general population. And there could be flare-ups and fallbacks and that limit daily activities. So psychological treatments could be done individually or in groups. And it's important to consult quickly to avoid these troubles get embedded into the individual. So in terms of intimate life and sexuality, IBDs can affect intimate life in different ways. There could be chronic fatigue, abdominal pain, fecal urgencies, and anxiety related to symptoms that can reduce sexual desire and satisfaction. Some treatments can also have side effects that impact sexual function, like hormonal therapy, and pelvic pain can make rapport uncomfortable, especially for women, and inflammation can have an impact on erectile dysfunctions. After pelvic surgery, there could be some dysfunctions that occur that can be transitory. So how do we manage this? Of course, with open communication with your partner, and choose moments where symptoms are not as present, adapting positions to minimize discomfort. And these are issues that you should not keep to yourself. You can discuss these issues with your gastroenterologist or your sexologist. So for the professional life, as an individual, we want to contribute to society and we want to live normally. So in certain workplaces, we don't need any arrangements. Sometimes there could be particular situations. In that context, that is a decision that is yours. You decide if you want to speak about your disease or not. It's a personal choice. But if you do choose to speak about it, focus on the practical facts rather than on focusing on the details. There will be a webinar on October 22, 2025. We invite you to hear us out on this issue with inflammatory disease and the professional environment. So, of course, flare-ups can bring about leaves and absenteeism, and sometimes we need to go to the hospital or get treatment. So we often favor the subcutaneous treatments because someone that has their own syringes is more flexible and can be mobile. So it is the social flexibility as well. You can travel, you can go on activities with your friends. So all of that is information taken into account when we make a therapeutic decision. So we speak of all of the options with our patient and we decide what is better for them according to their way of life. So that is something very important. Another fundamental issue, it is directly related to the relative immunosuppression that is activated by medication. So it is vaccines, vaccination. So we need to bring awareness to our patients. They need to be vaccinated for different diseases, but some vaccines need to be avoided. So, for example, we have rougeole, we have chicken pox. We have to wait. If the patient received the vaccine, we have to wait at least 4 weeks before we start biological treatments. But we have other vaccines for the flu and the pneumococ or hepatitis B that are vaccines that are secure, even with immunosuppressants. So also you need to surround yourself with useful resources. It's a major piece of the management of the disease. We have centers that are more specialized with experts. We have gastroenterologists, surgeons, radiologists, nutritionists, psychologists, and sometimes clinical essays or something that can bring something more in terms of treating inflammatory diseases. When we look at the plethora of medications that are in development, many of these clinics gives the opportunity to patients to use new medications that are not yet available on the market. So you can speak to your doctor about that. There are organizations in Canada on chronic diseases that offer support and services and that fight for the rights of patients. There are also digital resources. We have podcasts. There is the Emily Godlichi Scoop, the IBD series. And there are also other important tools. The management, the personal management of your disease. So some of you might use some digital applications like My God, an application from Chronic Disease Canada, which is a personal monitoring tool, but also a reference tool. There are resources specific to the Canadian health system. There are other applications like Bodycard, Heart Angry Enjoy, which is a Quebec startup that has set up the application to monitor symptoms and to help you communicate with AI. So inflammatory diseases with adults is a very important issue. There are strategies to adapt to them. A certain percentage of adults have spent their whole life living with an inflammatory disease, but sometimes the disease can show up when the person is elderly, after 65 years old. So if we look at this window, we assess that about 25% of patients that live with Crohn's or with UC are over 60 years of age. And another important fact, 10 to 15% of patients get a diagnosis after the age of 60 years old. So overall, most of patients with inflammatory diseases will have lived their whole lives in terms of diagnosis. Diagnosis is the atypical symptoms. So those are symptoms that are atypic, that are not typical, and there are systemic symptoms like fatigue and loss of weight or weight loss. So gastroenterologists often have a diagnostic approach that is more general. They will look at the different colics, colorectal cancers, microscopic colics, because some people use treatments and have anti-inflammatory medications that can cause intestinal troubles or intestinal ulcers. So there is also a challenge with comorbidity, though that means that there is a disease that stems from other associated diseases. So there could be cardiovascular diseases, high pressure, diabetes, osteoporosis. It could be neurocognitive troubles or deficiencies, and also this brings about a lot of issues in terms of exploring a diagnosis and a treatment. So if we look at the elderly population, we will focus on a multidisciplinary approach and target medications with the lesser side effects. We will focus a lot on prevention, and we will try to avoid interactions. So on this graph, you could see the elements that we can find, the medical molecules you can find for the elderly population. So we will focus as a priority those that are the safe, like vedolizumab and ustekinumab, and we will avoid the ones with a higher risk, like teoprine and corticosteroids. So we need to look at the severity of the disease and the possible interactions as well. So for the elderly patient, there is also a question of surgery. We need to do a pre-op test, and we need to do a cardiac assessment, a kidney assessment, nutritional assessment, which is very important. We need to favor the non-invasive techniques. So it's through paroscopy, laparoscopy, that we will find if there is a need for ostomy, and if we need to put in a temporary stoma. So vaccines for the elderly population or seniors, we need to give them a shingles vaccine. It's important. It's recommended for all IBD patients over 50. And it reduces the risk of infection that can be exacerbated by immunosuppressants. So in terms of comorbidity and access to care, we have three main issues that we must take into account. So seniors are at an increased risk for certain comorbidities, 2 or 3 diseases, compared to younger people. There is polypharmacy, which is a major problem that can contribute in terms of compliance and access to care, especially in remote areas. Sometimes there are issues with autonomy, and people with loss of autonomy is something important as well. So to maintain this autonomy, we need to try to assess functional capacities, adapt the home, and implement assistance. So it could be housekeeping, personal care, meal delivery, and remote assistance. So as for same for children, elderly people need social and family support. So we have role of family caregivers. Their relatives often play a crucial role in keeping older people with IBD at home. There are also services. So we have social workers that can help to navigate the healthcare system and identify available financial assistance. And finally, we have associations and support groups like Crohn and Colitis Canada. So end of life and palliative care, that is important to talk about this as well, because there are issues. We need advanced directives, the trusted person, and palliative approach. It doesn't necessarily mean an imminent end of life, but it can be integrated from the beginning of severe IBD management to improve quality of life and provide psychological support. So the conclusion is we need lifelong care. So we are April 23, 2025. So there is no cure, but the research is intensively working on finding a cure. But as of now, we're not there yet. What we're trying to do is improve the lifelong care from the childhood to adolescence to early adulthood, and seniors. So I hope that this presentation was insightful, and it will be a pleasure for me to take your questions now.
Thank you, interpreters. I'll be now talking in English. Dr. Jantchou, thank you so much for going through that very extensive information about each of the life stages and all the critical challenges that individuals face and the treatments that are approved for each of those life stages. We really appreciate you taking the time out. Now we will move on to the Q&A part of our webinar. I know it's 8:20, so we will try to get to the questions as quickly as we can. And if folks do have to leave at 8:30, please feel free. I hope Dr. Jantchou can stay on a little longer. Thank you. It is being recorded, so you will have access to the webinar after today. I would also like to point out that we got a lot of comments talking about English slides. So this presentation was offered primarily in French with English audio translation, but I will look into translating the slides and then also posting those on our website. And I will also share a link with everyone present here today via email with the French slides as a PDF. So you will have access to that after this seminar. I hope that answers a lot, majority of the questions that concerns that we had around the English slides. Okay, let's move into the questions. So these are questions that were collated during the registration form, and we've selected a few to share. And I just want to reiterate that these are general questions and do not replace the advice given to you by your doctor. So starting off, Dr. Jantchou, one question we got was, as I age, nighttime bowel movements are more frequent. Is this a concern?
Merci. I think I stay in French so that the translator won't be, what do you believe?
Sure.
Yeah. Okay. Donc, la question, effectivement.
Okay, so the question, yes, for these night bowel movements, what's crucial around the function of the digestive system is like other parts of the human body. There are modifications with age that are put in place. And when we're talking about the transit, we're talking about a movement of the intestine, the movement of the colon. There are many different factors. There's the disease, of course, the inflammation disease. It can have an impact, but there are also the possibility of having everything, the second brain, as we say, all the infections and the things that can be linked to the medications. And so when we explore the presence of these nighttime bowel movements, we're looking at the activity of the disease, but also the possibility of having an infection that is an additional cause. So it's important in front of a chart like this to underline it, to note it, and it's something that we ask the patients for a time of bowel movements. And in that context, if a disease is active, we adjust the treatments.
Thank you. The next question is, please address the use of Entocort for joint pain and inflammation in Crohn's, including long-term effects and tapering challenges.
Oui, la question de l'Entocort.
Okay, so the case here is like the corticoids. We already know the corticoids by the orally and the systemic therapies that we have to avoid. The cord has a liberation in the intestines, but the data show that even if it is made to have this locally, we could have a systemic passage and have effects on the osteoporosis, hypertension, and we're really talking about treatments that are prolonged for many months and years possibly. And so if a patient needs that, it's probably there's a necessity of optimizing his treatment in that context. That we will introduce certainly other medications that are not as dangerous or less harmful. The action of that medication on bones is also something that was demonstrated in a study, but those are treatments that are also to be avoided because there are other alternatives that there's a benefit for security.
Next question is, how often should one have a colonoscopy after the age of 75?
Alors, ça, c'est une excellente question.
So that is an excellent question. The tests are done usually at the beginning of the disease, the first colonoscopy, and after the disease is not in a flare-up, we every 8 years. But after that first test, we will do a follow-up that can help after 5 years, after 75 years old. Most of the time, if the other colonoscopies were normal, the frequency can be spaced out. But we can't define specifically one specific number for the frequency that will be X number of years, because it depends, first of all, on the activity of the disease, the family risk, and the possibility of offering something to the patient if we find polyps or cancer. So that balance of risk, like every procedure, there are risks, and are we ready to offer something if we find a polyp or a cancer? So those are discussions that could be really individual. But most of the time, the colposcopy, it will depend after what we find in the colposcopy.
The next question is, are there any studies on changes in disease activity or medication effectiveness during menopause and menopause? And we actually had multiple individuals ask us this question, so I've just consolidated into one. Thank you.
Thank you. C'est une excellente question.
That's a great question. We've did a little study, and we fell on a work that was recently done, and it will be presented at the Congress of the DW in month of May, and so we're almost a few weeks away from that Congress. So it's a meta-analysis that the authors have put in place, and a review of everything that's being done in literature to identify 14 studies. There were studies in cohorts that we're talking about students, patients that were followed for several years, and we're talking about cases where some that have disease versus those who don't have diseases, and then cross-sectional studies with photographs, and being in the menopause could make it worse activity of the disease, and other found their inverse or reverse, and the benefits by mixing all the studies that we're being told that we don't actually have the evidence to be worried above and beyond the fact that the hormones we know have an influence in this disease. And so these phenomenon are seen during the puberty, and so where there are a lot of ratios, the sex ratios are different. In pediatrics, we have more children, and we see more boys and girls, and among adults, it's more the women and the men. And so that ratio during the menopause can influence the activity of the disease. But currently, there's no data that brings us to believe that it is to have more concern. Thank you.
The next question is, for people over 65, do occasional mild flares while on biologics mean a treatment change is needed?
Alors, je dirais pour cette question,
I would say that for this question, we will broaden it. Obviously, at 65 years old, 60 years old, changing the treatments, it's also increasing the risk of immunosuppressors if we are thinking of using medication that is stronger. It is difficult to look at that globally because certain symptoms can be clinic and others can be biological or both. And oftentimes patients will need, first of all, when we ask them or question them and to see if there's relief from their clinical symptoms, and biology doesn't interest them. And so one of the things that will be done oftentimes is to evaluate if it is the disease that is active, and if the disease, if it is active, linked to a resistance of the treatment, or if it's an active disease because there's infection. So repetition of that thrust is probably an indication that treatment is not effective because it harms the well-being. An isolated flare-up can be due to other factors during a cold or other influenza or viruses. So that is essential to have a close monitoring when we have flare-ups that are often repeated, and we have to avoid complications on a long-term basis.
We can put together two questions. So one question was, what vitamins should an elderly person with Crohn's be taking? And another question we received in the chat was, vitamin D supplements are often recommended for IBD patients in conjunction with treatment. Again, relatedly, are there any other vitamin supplements that could be offered as recommendations, such as L-glutamine?
Oui, la question des vitamines, c'est important.
Yes, the question of vitamins is quite important. There are now enough data to be able to say that the patients with IBD have a deficiency in vitamin D in particular, no matter what the age is, and those that are found more standard in the supplementations, it is beneficial, and it's not dangerous to take it with other treatments. The other vitamins that we can give, like a B12 for the elderly, B9, or even the question of iron, are things to take into consideration because the absorption at that age can be a bit more limited than the younger ones. So nutrition can lead to deficiencies, and have multiple mixes of vitamins could regroup in one capsule different vitamins. That could be an approach that for supplementation that is well tolerated.
Thank you. The next question is, how long can someone safely stay on bimethyl Remicade infusions?
Actuellement, les données montrent qu'on peut rester longtemps. Comme je l'ai mentionné,
we see that they could stay for quite some time, and it started in the year 2000. We're in 2025, so the patients that are well controlled under that treatment have a tendency to stay on it. There are no dates to the end. The crucial point is that there are studies that were done 5 or 6 years ago, where they had randomized the patients to continue the drug or stop the drug after 5 times or 5 years with the disease was silent. But more than half of them have relapsed, and relapsed severely. So the idea is to say that if we have a treatment that is well controlled, we maintain it, but we can do what we call a de-escalation, in the context that if or for 4 weeks we can go to every 6 weeks. If we're at every 6 weeks, we could go to every 8 weeks. But the maximum for certain treatments like infliximab is every 8 weeks. Certain patients that are under treatment, infliximab plus immunosuppressors, when it goes very well, we could keep it just infliximab. But the question of we're trying to control the disease, and there's a risk of relapse, so we prefer not stopping them.
The next question is, are there age-related differences in nutrient absorption and IBD management in the elderly?
Oui, oui, oui. L'absorption.
Yes, absorption of nutrients can be weak and decreased for the elderly, but also the intakes that can be weaker linked with in connection with diet that is not diversified or doesn't have enough nutrients. So the both factors mixed together make that the risk of lack of minerals and deficiencies will even be more important, as we were saying before, the possibility of supplements.
The next question is, I know so someone wrote in, I know medication is key, but should one also change things like dish detergent and probiotics? I guess it's a question around the environmental aspect.
Oui, oui, oui.
Yes, absolutely. A lot of things have been done to try to understand how we can minimize those flare-ups and improve the evolution of the disease. There even was work that was done for toothpaste around all that concerns cooking. Example, the question of detergents, washing. There's not enough proof to show that it will make a difference when we use the detergents for the dishes, for example. The probiotics have shown that it can be effective for the treatment of the disease that's used right now, especially when there are diarrhea after the onset of the antibiotics that can be used afterward, but as a treatment, as a disease of colitis, it's not really a benefit to take it on the long term.
So we only have 4 more questions, just to let you know, Dr. Jantchou. The next question is, how do you manage Crohn's during university, stressful periods, or lifestyle changes, situations where you're living away from home?
Oui, c'est un point crucial. Comme on le mentionnait tout à l'heure, dans les changements de vie, la transition pédiatrie adulte, ça accompagne aussi une transition de études secondaires, études universitaires, les changements de mode de vie, les parents qui cuisinent, on se met à cuisiner tout seul, on a des conjoints, on n'a plus de conjoints, on se sépare. Donc tout ça, c'est des éléments qui peuvent impacter la maladie. La première étape, c'est effectivement de savoir bien se connaître, donc connaître soi-même, savoir quels sont les éléments qui
The first step is to really know ourselves well, to know what elements can destabilize us, how we can manage frustration, how we can manage stress is really important, and routine. A routine is important. It needs to be stable, even if sometimes we can be destabilized. And also the treatments are important because during university periods, we can have perfusions. We need to be regular with our treatments and do not hesitate to reach out for help to help you with emotional challenges. Have consultations, ask for help. That's super important.
Okay. The next question is, how do you manage joint pain and other aches when NSAIDs are not an option and Tylenol is no longer effective?
Oui, les douleurs articulaires, souvent associées aux maladies inflammatoires, peuvent évoluer indépendamment de la
Pain
maladie
associated with inflammatory diseases can evolve independently from the digestive system. So we know that more and more we have biological treatments or immunomodulators that help relieve patients. That is often the alternative when other treatments no longer work, because there's a direct action on the inflammation targets. Using those vehicles really helps patients.
The questions that came during the meeting. So there's just three questions. The first one is, you recommended the shingles vaccine, but which other vaccines aside from childhood vaccines should be taken? Thank you. That's from Sherry.
Yes, pour la vaccination, le vaccin pour le pneumocoque, c'est important.
So vaccines for pneumocoque is important, and also for the meningocoque vaccine is important because of the immunosuppression. there is a risk to contract those infectious agents. So we need to take those vaccines.
Next question is, does diagnosis in children reduce pain and flare-ups in the future compared to being diagnosed as adults?
Can you repeat the question? I just
Sure.
missed it.
So actually this question was shared in French, so I'm translating it to English
Okay.
back to you. But the translation is, does diagnosis in children reduce pain and flares in the future compared to being diagnosed as an adult?
Oh, oui, la question effectivement de l'évolution de la maladie lorsqu'on est diagnostiqué.
Okay, so the question about the disease's evolution when there is early diagnosis. Well, I would say it's the initial severity. So some diseases are more severe for a child compared to certain adults. But when the diagnosis is made at a preliminary stage, there are many patients that can respond well to treatments. So they will transition to adulthood. Most of the time, better, even in severe cases. For adults, one of the issues is the early use of biological medicine. But this is changing because there is also the therapeutic target pathway, and that could decrease the severity
IBD pain
over time.
Related to back and arm pain?
Les douleurs abdominales peuvent être différentes de l'évolution.
Abdominal pain could be different and separate from the disease's evolution. So we have abdominal pain that is in the context of irritable bowels, and it's pain that is not related to the activity and of different types. So there are pains and sores that could be limited to the intestines, but other pains could be also around the stomach and all over the gastric system. But if there is pain in the skin, in our back, or in our shoulders, or elsewhere, we will talk about other joint diseases that will evolve independently from the disease.
Today, I do want to extend a really heartfelt thank you to, again, Dr. Jantchou and to Jessica for taking the time and for sharing your expertise and experience so that our IBD community has more information and they feel more empowered and better equipped to handle all the upcoming life stages as they go through their IBD journey. So to wrap up, again, thank you to everyone here for attending today. If you have any questions or require further support, please email us at learn@crohnsandcolitis.ca. Thank you for being patient with us today as we navigated some challenges. And hopefully in the next session, we will have all those kinks figured out. Lastly, you can also feel free to follow us on any of our platforms at Get Gutsy Canada, where we provide updates and reminders for all of our upcoming events. So that concludes the session for today. Again, have a wonderful night and thank you again for joining. Take care, everyone.